I'm Dr. Fakri Robari, and this is urinary tract infections in adults. The basics are so important. Urinary tract infection is the most common bacterial infection in the ambulatory care setting in the United States. Nearly half of females will develop a UTI in their lifetime, with 25% recurrence within 6 months. And over half of all recurrent UTIs are caused by the same initial bacterial strain that caused the first infection. Pyelonephritis is much less common than cystitis, even in patients with untreated cystitis or untreated asymptomatic bacteriuria. Risk factors for UTIs include sexual intercourse, use of spermicides, previous UTI, a new sex partner, and a history of UTI in a first-degree female, because there are some genetic components into it. Now let's take a look at the anatomy of the urinary tract. So on the left, you're looking at the urinary anatomy of the females, and on the right, you're looking at the urinary anatomy of the males. Note that urethra is what's connected to the bladder. So the urine will actually exit the bladder through urethra in both females and males. So there's urethra that goes through the penis and is connected to the bladder. And the ureters connects the bladder to the kidneys in both female and males. Now in females specifically, the urethra is very close to the rectum. It's very easy for bacterial translocation from the GI. So the GI, so gastrointestinal organisms, can easily translocate to the urethra and then go up to the bladder. So cystitis is much more common in females compared to males. In males, you can see that the opening of the urethra is much further from the rectum. So it's much more difficult for translocation of bacteria from the rectum all the way to the urethra. Also look at the anatomy. So it's much more difficult for bacteria to travel up the urethra in the males. So therefore, urinary tract infections are more common in females compared to male. Another thing to note is that in females, when females get urinary tract infections, the bacteria can oftentimes colonize the vagina. And in males, if males get UTIs, the bacteria can also colonize the prostate. So the prostate is also involved oftentimes when a man gets a urinary tract infection. And in men, the bacteria can also cause infection of the urethra. So urethritis is possible, as well as epididymitis. So epididymis is this area that's connected through the prostate to the same pathway. In general, urinary tract infections are divided into two categories. The upper urinary tract infections, which is primarily pyelonephritis. Pyelonephritis is the infection of the kidneys. And the lower urinary tract infection, which includes cystitis, epididymitis, prostatitis, urethritis. So the bottom three are specifically in men, and cystitis can happen in men and women. Let's take a look at the pathogenesis of urinary tract infection. So as I explained on the previous slide, is that bacteria can oftentimes translocate from the gut, specifically from the rectum, and go through the urethra. And then once they go through the urethra, they can colonize the urine in the bladder. This can cause inflammation and an immune response, specifically neutrophils, which can cause epithelial damage leading to the burning sensation in the bladder. Now for most people, this would be the end and the infection will be resolved. However, for some people, the bacteria can ascend even further. So through the ureters, the bacteria can actually ascend all the way up to the kidneys, and they can actually colonize the kidney tissue, resulting in inflammation and damage to the kidney. There are a lot of vasculature in the nephrons, so the bacteria can easily get into the blood, and that could lead to bacteremia or infection in the blood. In general, there are three ways to get urinary tract infection. The first way to get urinary tract infection is through the ascending pathway, which I just described, with the bacteria translocating from the gut to the urethra and ascending to the bladder and then to the kidneys and eventually to the blood. Another way is if the bacteria actually come from the blood. So if somebody has bloodstream infection, because the blood goes through the kidneys, the bacteria can actually go from the blood to the kidneys and then from the kidneys to the bladder, causing cystitis. And the third way of getting urinary tract infection is actually through the lymphatic system. The lymphatic pathway is not as common. In fact, the evidence for it is actually from animal studies. Now let's take a look at reliable resources. IDSA is the Infectious Diseases Society of America. It's the organization in the United States that develops clinical practice guidelines for infectious diseases. The first guideline that you should be aware of is the 2009 IDSA guidelines for catheter-associated urinary tract infections in adults. This is the guideline that clinicians typically refer to for complicated UTIs. The second guideline is the 2010 IDSA guidelines for acute uncomplicated cystitis and pyelonephritis in women. The third one is the 2016 IDSA guidelines for candidiasis. This guideline includes recommendations for candiduria, which is the urinary infection caused by candida, which are fungal infections. You will learn about fungal infections on a different topic. And the last one is the 2019 IDSA guidelines for asymptomatic bacteriuria that were released just a few months ago. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for UTIs. Let's take a look at some anti-infective agents that are commonly used for the management of UTI. Historically, fluoroquinolones have been frequently used for UTIs. So ciprofloxacin is one of the commonly used fluoroquinolones. The mechanism of action of fluoroquinolones involves inhibition of bacterial DNA synthesis, resulting in rapid bacterial cell death. And this happens by inhibition of two different enzymes. So they can inhibit DNA gyrase, often in gram-negative bacteria. They can also inhibit topoisomerase 4, often in gram-positive bacteria, which results in DNA synthesis interruption. Fluoroquinolones are available as PO and IV for the most part, which can be used for UTIs. Now, there are other formulations, for example, ear drops, eye drops that are not covered in this topic. Fosfomycin is only available as oral in the United States currently, and an IV formulation is under development. And the way it works is that it inhibits MUR-A, which essentially inhibits initial step in bacterial cell wall synthesis. Nitrofurantoin is also only available as an oral option, and there are three proposed mechanisms of actions for it, which include inhibition of ribosomal translation, bacterial DNA damage, or interference with the Krebs cycle or citric acid cycle. Finally, we have the combination of trimethoprim, sulfamethoxazole, which together are available as both oral and IV, which are used commonly for the treatment of UTIs. And the way they work is that sulfonamides inhibit the formation of dihydrofolic acid, and trimethoprim prevents the next step, which would be the synthesis of tetrahydrofolic acid, which in turn inhibits DNA synthesis. Now, let's take a look at some beta-lactams. So, pivmecillinam, which is an aminopenicillin, and other aminopenicillins include amoxicillin and ampicillin. But unlike those two agents, pivmecillinam is an excellent agent for use in urinary tract infections. Although its bioavailability, similar to other oral beta-lactam, is low, about 25 to 35%, it does achieve high concentrations in the kidneys. Now, this is a prodrug, so the active drug, which is mesillinam, it is primarily excreted in the urine, so 80% of it goes unchanged in the urine. And just like any beta-lactam, they act by cell wall synthesis. They bind to penicillin-binding proteins, and it is bactericidal. Now, some other beta-lactams that are commonly used in UTIs is first-generation cephalosporin cefazolin, which is only available as IV. Which has activity against E. coli, but it depends on local susceptibility rates. So E. coli may or may not be resistant to cefazolin. Ceftriaxone, which is a third generation cephalosporin and is also available as IV, has much more stable activity against E. coli. So in general, if we don't know susceptibility results, ceftriaxone has more reliable activity against E. coli. And for more severe UTIs, typically aminoglycosides are also available as an option. So gentamicin is one of them, and in general, aminoglycosides inhibit protein synthesis by binding to the 38 subunits of the ribosome. But there are more severe toxicities with aminoglycosides, including nephrotoxicity as well as ototoxicity. Let's take a look at the adverse effects of these antibiotics. Trimethoprim can lead to anemia, leukopenia, thrombocytopenia, hyperkalemia, and hyponatremia. And hyperkalemia is something that occurs in clinical practice often and is something to monitor with patients. Trimethoprim can also inhibit the secretion of serum creatinine in the kidneys, which means that artificially serum creatinine will be increased, but doesn't necessarily mean nephrotoxicity. Sulfamethoxazole, however, can cause nephrotoxicity. So because these two come together, so together this combination is considered nephrotoxic. And sulfamethoxazole, which is a sulfa drug, that component can cause rash, photosensitivity. It can also cause GI upset like nausea, vomiting, diarrhea, as well as hepatitis, anemia, thrombocytopenia. And it is recommended that the patients actually take this combination with at least 8 fluid ounces of water in order to avoid formation of crystals in the kidneys, in order to avoid or at least reduce the risk of nephrotoxicity. It is also advised for the patients to use sunscreen and avoid tanning beds because of the photosensitivity. Nitrofurantoin can also cause GI disturbances as well as CNS effects, such as headache and drowsiness. It can also lead to allergic reactions that often present as leukopenia, granulocytopenia, eosinophilia, and hemolytic anemia. And hemolytic anemia is often present in people with glucose 6-phosphate dehydrogenase deficiency. It can also cause peripheral neuropathy, interstitial pneumonitis, and it can also make the urine color change to brownish color. And with chronic use, it can also cause pulmonary fibrosis. Lastly, it can cause hyperkalemia. It is recommended that nitrofurantoin be taken with food to improve absorption and avoid concurrent magnesium products, which can reduce the absorption. Phosphomycin is currently available as oral, and it comes in packets that include powder, and the patients need to mix it with 3 to 4 fluid ounces of cool water, so it should not be done in hot water. And it can cause diarrhea, nausea, headache, vaginitis, as well as dizziness, abdominal pain, as well as rash. Now, a lot of bad things happen with fluoroquinolones in general. So let's focus on ciprofloxacin. So with ciprofloxacin, like many antibiotics, GI disturbances can occur. So nausea, vomiting, diarrhea, abdominal pain. But with fluoroquinolones, you can also have CNS effects like headache, dizziness, hallucination, delirium, and in some cases, seizures have happened, including in patients who had underlying neurological disorders, and also like patients who were taking NSAIDs. So NSAIDs can increase the risk of having seizures with fluoroquinolones. There's also been reports of peripheral neuropathy that may be irreversible, as well as arthralgia and joint pain, tendon rupture or tendinitis, and these basically occur mostly in elderly patients over the age of 60. They are at high risk. Fluoroquinolones can also lead to QTc prolongation. Now, ciprofloxacin has the lowest risk compared to other fluoroquinolones, but the risk still exists. It can also cause rash and photosensitivity. It is recommended that patients avoid taking any dairy products. So anything that includes a cation such as calcium should be avoided. So they should be separated by at least 2 hours. And just as in any product that causes photosensitivity, patients should use sunscreen and avoid tanning beds and avoid excessive exposure to sun. Let's take a look at different formulations of nitrofurantoin. So when first it came to the market in 1952, it was in macrocrystalline form, which, it had improved absorption, but it also came with a lot of adverse effects, specifically GI adverse effects that made it difficult to tolerate for patients. Later, by 1967, the macrocrystalline formulation was developed that improved GI adverse effects so people could tolerate it. Unfortunately, it came at the cost of absorption. So because it was not absorbed, this had to be taken 4 times a day. And this still is available on the market as macrodantin. And later, a mixture of macrocrystalline and macrocrystalline formulation was developed. So about 25 milligram macrocrystalline plus 75 milligram of macrocrystalline. So this was a little compromise. So improved absorption with a little GI adverse effect. So Macrobid, which is the preferred nitrofurantoin formulation, is available on the market, and this is 100 milligram given 2 times a day BID, and that's in the name Macrobid BID. Now, it is contraindicated in the package insert in patients with creatine clearance less than 60. However, clinically, we do use it as long as creatine clearance is over 30, and you can see Beer's criteria to support this recommendation. Now, here's how the spectrum of coverage of nitrofurantoin compares to some of the other oral agents. So nitrofurantoin is active against MSSA. It may or may not be active against MRSA, so it has to be tested. It is good against VRE and excellent activity against E. coli, so the resistance pretty rare. However, if it is an ESBL producing E. coli, it is likely to be resistant to nitrofurantoin as well. Whereas phosphomycin and pivmesolinam are stable, where pivmesolinam is a beta-lactam, so it's stable against ESBL, and ESBL producing E. coli typically happen to be susceptible to phosphomycin as well. So phosphomycin and pivmesolinam good options for ESBL. ESBL producing also tend to be resistant to trimsulfa as well. Now, pivmesolinam is very targeted at E. coli, Klebsiella, and some of the Enterobacterales. And you can see that it hardly has activity against some other organisms, specifically gram-positive. However, because we get very high concentration of pivmesolinam in the urine specifically, it does happen to kill some of these gram-positives like Enterococcus, but in general, it's considered at least in vitro to be resistant. These organisms are resistant to pivmesolinam.
Because there are different formulations of nitrofurantoin, and if you're working with the generic, it just says nitrofurantoin on it. So it's important to be able, as pharmacists, to distinguish between the 2 formulations. So as you can see, choice A, it actually tells you that this is monohydrate macrocrystals combination, whereas the second is just macrocrystals. So this question is which is the generic for Macrobid. The correct answer would be A. It also tells you here, so A is Macrobid. It says that it's dosed twice a day, take it with food. Whereas the second option, it tells you, let's see, QID, so 4 times a day with food. So that's how you know choice A is Macrobid. So as pharmacists, you should be aware of, if the doctor wrote for Macrobid, don't dispense the second option, especially if the instruction says take 1 pill twice a day. You do not want to give them this because it's not going to be absorbed as much, and you're going to have failure, treatment failure.
Now let's take a look at sulfonamide allergy, which is often referred to as sulfa allergy. Now about 3 to 8% of patients report experience with sulfonamide allergies. And in general, all sulfonamides, which can be divided in sulfonamide antibiotics and sulfonamide non-antibiotic agents, they basically all contain a sulfa moiety. And then sulfonamide antibiotics also contain additional substitutions at N1 and N4 positions. And the evidence currently suggests that these substitutions at N1 and N4 are the primary determinants of drug allergy instead of the common sulfonamide moiety. So Based on the evidence that's available currently, there is a very low risk of cross-allergenicity between sulfonamide antibiotics and non-antibiotic agents. So when you hear a patient have a sulfur allergy, you should determine if it was due to a antibiotics sulfonamide or a non-antibiotic sulfonamide. And in general, sulfonamide non-antibiotic agents include loop diuretics like furosemide, thiazide diuretics, so hydrochlorothiazide, for example, sulfonylureas, triptans that are used for migraine, acetazolamide, celecoxib, which is a COX-2 inhibitor, as well as some protease inhibitors for HIV, such as darunavir. And sulfonamide antibiotics, for the most part, include sulfamethoxazole, which we use for UTIs in combination with trimethoprim. But there's also sulfadiazine as well as sulfasalazine. So rechallenge and desensitization strategies may be appropriate for patients with sulfonamide allergy with delayed maculopapular eruptions, but alternative treatment options are more appropriate for patients with severe infections.